semiconductor facilities, advanced pharmaceutical manufacturing plants, and world-renowned airports. In her current role as Director of Facilities Development in Singapore Health Services, Hsien oversees the design and development of healthcare infrastructure facilities in the public healthcare cluster, which includes 4 tertiary hospitals, 5 national medical centers, 3 community hospitals, and also some polyclinics. She speaks regularly in healthcare design conferences and has also participated actively in developing several healthcare design guidelines. Welcome, and we are very glad to have you with us. You have an extensive experience, and I'm sure everyone is very excited to hear what you have for us to offer.
Thanks.
Next up,
high introduction.
Next up, we have Chih, who has been in the healthcare operations over the past 16 years in both private and public healthcare institutions. He is currently working in Alexandra Hospital in Singapore, where he looks after all the surgical specialties and procedural facilities. He had a special interest in operations planning and design and was in the pioneer operations team to set up Mount Elizabeth Novena Hospital in Singapore. He is part of the campus redevelopment team to build the future Alexandra campus in 2030. Welcome. We are very also excited to have you. I am particularly excited to ask you about the future development of 2030 Alexandra, because I'm sure there are so many lessons learned. So we will talk about that. Last but not least, we have Datuk Dr. Kuljit Singh, who earned his master's in otorhinolaryngology from University Malaya, Kuala Lumpur in 2002. Prior to that, he served at Hospital Kuala Lumpur and Hospital Tangga as the ENT's clinical specialist in HKL 2002, lecturer and ENT specialist at University Malaya Medical Center, UMMC, and now consultant ENT surgeon at Prince Court Medical Center, PCMC, since 2007. An active member in Malaysian Medical Association, MMA, since 1996. And he has contributed and engaged himself in various roles at state and national level of MMA, where he also served as the Honorary General Secretary from 2013 to 14. In terms of networking and foreign collaborations, he has conducted meetings and presented in all the ASEAN countries and has a great networking with all the leading ENT doctors within the region and many other parts of the world. He served as the Malaysian Society of Otorhinolaryngological ENT president in 2007 and awarded meritorious awards by the society. Excuse me. He leads the way on minimal invasive sinus surgery and recently using imaging guidance system in navigating sinus surgery. Currently, he serves as the position of medical director at PCMC Kuala Lumpur and is also the president of Association of Private Hospitals Malaysia. His passion is to serve towards the healthcare of the people of this country. Welcome, Dr. Singh. You have an extensive experience and we can't wait to hear your clinical input into this. You know, before this, I had to practice saying otorhinolaryngology, so I hope I did well. So first up, as a warm-up, I'd like to ask the panel to tell us a little bit about their experience during you know, the past few months, well, since March, and you know, working with this pandemic, COVID. I'm sure it impacted everyone's career. Of course, it's going to be something we talk about as we plan for the future facilities for this pandemic and future pandemics as well. So I'd like to go around the panel, and if everyone can tell us a little bit about their experience during this turbulent time. And maybe I'll start with Hsien.
Yeah, first of all, I'm really glad that I can actually join today's panel. And I think all of us come from different backgrounds. Really, there's a lot that I can learn from everybody here. So actually, I would like to say that when COVID-19 hits us, actually everybody get affected. But being in public health care, and that would mean that actually all our hospitals are really right in the midst of it, handling COVID-19 patients. And even though we are not the frontline clinical department, all our people are mobilized to help out our frontline colleagues. Yeah, first and foremost is really get ourselves settled down, and get the process and place ready to receive all the COVID-19 patients and support all our colleagues. But obviously, the other important part is that my department being the one that manage all the infrastructure development projects. And we are actually doing many small projects and medium-sized projects. And that will mean that all those are impacted, all right? Whether they are construction sites or whether they are in the midst of planning and design. And really at that moment is really to settle down all the project and actually understand what is a real impact. Now, obviously, all of us know that during that time, we don't know what is ahead of us. So therefore, at the beginning, we didn't really know what to plan. But slowly, it became clear that in Singapore, we call that circuit breaker. Okay, I'm not sure it's really immediate obvious what does that mean. It means a lockdown. When the lockdown, it becomes very clear, and we understood that it's not going to be just a few days affair. And the next big thing is really to plan how is the project going to be impacted, and what are we going to do about the project to assess the impact and discuss with our consultant contractors moving forward, what can be done, what cannot be done, and most importantly, what we are users, the impact to all these projects. And obviously, the next thing is how to work within COVID-19 when you really cannot go out and you cannot meet face-to-face. Therefore, the technology comes in. I wouldn't elaborate more. I'm sure later we will have a very detailed discussion. So I will hand over to my other fellow panelists.
Yeah, Chih. So my experience is slightly different because I'm managing the operations of the hospital. So we're really on the ground. So when COVID first came and started around February, once news came out in China from our SARS experience, we were getting the hospital ready and prepared. So we were trying to increase the capacity of our isolation facilities in preparation for the pandemic to come to Singapore. We were just making sure we have the resources, personal protective equipment. We were bringing them in, making sure we have enough supplies. So Singapore as a whole has learned quite a lot from pandemic, since SARS, and we had little pandemics that came about along the way, bird flu being one, and even MERS-CoV, which is still around. So those are all experiences that we have learned, and what we have done is we have a response plan to make certain arrangements, especially in terms of getting our facilities ready for the surge in patients. So as the disease profiles begins to be made better known, and the first case comes to Singapore, by then the hospital would have already gotten all the rooms ready, all the staff ready, and it's really trying to assess how severe the situation is. Thankfully, in Singapore, the situation didn't go as bad as we planned for a big part of it, until much later when the dormitory situation, the foreign workers in dormitories had a huge spike. That's when the strategy really changed, because no matter how much capacity we had, we wanted to make sure that there was not enough, because it was going to be overwhelmed. But thankfully, because the foreign worker population were younger, so the chances of them using the ICU was less. So even though we were spec'd to, and we were doing quite a bit of conversion to try and increase the number of intensive care facilities in a very short period of time, which we managed to do, it wasn't fully utilized, thank God. But what we instead had to do was to create a lot of almost like residential places for our patients with COVID who are young and fit, and who could actually, who didn't require so much medical attention. So yeah, the response changed very much from equipping ICUs and making more ICUs to building tentages in our football field to house these patients. So yeah, it's definitely a very exciting time, and as we are still in the midst of it, we are also learning lessons about. And one of the big lessons I think I personally learned is how important it is to design flexibility into your facilities so that you can respond to such emergencies, because the situation can change in a span of hours. Okay.
Thank you. Dr. Kuljit.
Okay, thank you. On the medical front, I think it was pretty global, but in Malaysia, doctors were a little bit worried when the COVID hit us. We were not very sure, like what my earlier speakers had mentioned, what would be the intensity of care that would be required for COVID. Coronaviruses has got this very peculiar behavior, and it is not like a typical other upper respiratory tract virus that is quite known to us. And almost every coronavirus has been quite devastating. Now, our main worry was that should we need infrastructure in hospitals to house patients that needed intensive care. That was something which we were very worried of. When we looked back in countries like Italy and I think some of the other European countries, they had a situation where they could not give intensive care to many of their patients, and many of their patients died because of poor infrastructure. It's not because of technology, it wasn't because of manpower. They had all of this, but they could not house them in any place to give them treatment. That was our biggest worry. Our hospitals by design, if you look, especially if it's a private hospital, by design, the intensive care units are usually pretty small because we tailor our intensive care units for the type of work that we do. But if you look at tertiary referral hospitals in the public sector, they might have slightly larger, may be able to cope, but even then they can get overwhelmed. So we were thinking, the medical fraternity was thinking, like what the earlier speaker said, that in the future, if engineering, architecture, expertise can sit together to have systems whereby wards can be converted into ICUs when you require them. It's just like airports in the world, which can become an army airport when you need them. Otherwise, they can run a domestic traffic at other times. In the same formula, during an emergency, we should not worry because everything can be converted, ready to house such kind of pandemics, which I don't wish for it, but I'm afraid that we might face this kind of pandemics as we grow along. I hope in my lifetime I don't face another one like this, but there is no guarantee. So we have to be really, really be prepared because COVID has taught us a lot. There is a silver lining from COVID. A lot of industries learned a lot from COVID because we took for granted many of our processes in the past, that we had this attitude that nothing will happen, but it happened very fast, and that has actually taught us a lot.
Yes, and I think everyone raised really good points. You know, during my experience at the Brigham and Women's Hospital in Boston, we experienced very similar issues. And I want to jump on that point about designing more flexible and adaptable hospitals and move it to Siu Kin, and maybe you can talk to us a little bit about how we can actually do that. How can we better design, you know, the adaptable rooms that can be, in case of an emergency, turned into ICUs or critical care units or other critical resources that we need in case of a pandemic.
Thank you. So actually, I would like to approach this is not just a matter of rooms from our experience in public healthcare. Really that actually this approach in designing flexibility in, I think all the time we were doing that. But it's just that what this COVID-19 has caught us by surprise is really the scale of it. I mean, how many patients are we talking about? I think just now my fellow panelist, Hsien actually said, yes, since SARS period or MERS COVID, we were actually thought that we were ready. because they have increased the number of isolation rooms we have. We also have, we thought that we have enough ICUs, but then really we didn't expect that many COVID-19 patients can come to us. So we have to look at the scale that we are looking at, and you look at the speed, all right? I think what we learned from COVID-19 is really that whatever flexibility you have, it must be readily available, because the ramping up is so fast. And all of us know that during that period of time when lockdown comes in, suddenly all the labor available in the market dries up, because many of, unfortunately in Singapore, we rely a lot on foreign workers to come in to do constructions. Although locally we do have a lot of construction manpower, but then there's also a lot more, right? And suddenly when the lockdown happens, they are not available. And even if labor is available, supply is not there, all right? Because worldwide transportation just stopped. So therefore, whatever we have, we must bear in mind that it has to be available even during a lockdown situation, all right? You can't afford to ship something from afar. Now, so with that in mind, that means there will be a lot of flexibility need to be built in and readily available. But all of us know that whether you are public healthcare or you are private hospital, you can't really build a lot of ICUs. You can't really build a lot of isolation rooms. They are not just expensive to build. They are also very expensive to operate. Therefore, the concept will be something has to be really, can be operated as normal, right? Without a lot of additional utility, resources, manpower, etc. You can operate like a normal ward, normal ICU, whatsoever. But at the, I wouldn't say a push of a button, perhaps it's within 1 to 2 weeks, the longest, or a few days preferably, it can quickly get converted and we can switch off M&E equipment, and there you have it, isolation rooms or ICUs. Really, that's the approach that we are looking at. But step back a little bit further. Before we build in such flexibility in public healthcare, we actually have to look at what type of healthcare facilities are we looking at. I mean, speaking from the view of SingHealth, I'm sure also my colleague from Chih, actually under our cluster, we call it healthcare cluster, we actually have different types of institutions. It can be acute hospital, quaternary, tertiary acute hospital. It can also be the intermediate community hospital where our not so acute patient get recuperate, right, and rehab. And it also could be even further downstream primary care. So whatever we convert must be appropriate for the type of patients we would expect during such a situation. Therefore, actually, it all starts with really a dialogue with our senior management and also all our users, colleagues out there, to now to work with our Ministry of Health. What kind of patient do we expect to be accommodated in this particular institution? Are we looking at very, very acute COVID-19 patient? I will use COVID-19 as an example. Are there the very acute patients that need ICU or very acute care? Or are there those subacute ones, which already the critical phase is over in the acute hospital and we know that they cannot recover so fast, therefore we come to our community hospital? Or are they, like just now what Hsien said, is that those are the young and healthy but unfortunately get infected? Therefore, what they need is a lot of accommodation to house them so that they are segregated from the rest of the general public who might be vulnerable or susceptible to COVID-19. So any design, really we have to design with the people in mind. Now, once it's clear what kind of patient we are designing, obviously next stage is what kind of infrastructure do we need to cater for this group of patients? Do I need the top-notch isolation facility? In Singapore, we actually have one facility called NCID, all right? So NCID really have the best isolation facilities, but it's very expensive to build and very expensive to operate. Therefore, only our acute hospital may be able to afford a little bit more of this, but the rest of them, we will have to actually have perhaps the design will tweak to cater for the less acute patients, all right? So now, with this in mind, then in that case, actually, it's also a lot of dialogue with our user. Now, during peacetime, nowadays we always use this word, during peacetime and wartime, meaning peacetime normal operation and wartime pandemic comes. during peacetime, what is your workflow? And during wartime, what is your workflow? And if you are greenfield, well and good. I think that's very easy and easier to now imagine what kind of facility you are going to have. And normally we'll need to start with one model or other. But I think the big question is, do I start with designing a peacetime first or designing a wartime first? I think that's a, now we actually have one ongoing project. And actually our experience realizing that you cannot just focus on one when you start. You actually have to run in parallel. Because a simple example of zoning, because just like COVID-19, it doesn't happen overnight. Suddenly all your patients are COVID-19 patients. We all know that people still fall sick, all right? And there will be also patients who have critical illnesses that still need surgery during COVID-19. Therefore, any of our facility at any one time, you will have a certain proportion of really infectious patients, and many others are vulnerable patients that is not infectious. So we have to design the facility to be able to operate perhaps in a hybrid mode. Except NCID, which is specialized in infectious diseases, all of us will have to have zoning such that all our non-infectious patients are safe in our hospital and they don't get infected. And while the other infectious patients receive the best care, and what our design need to cater for is to protect the other group of patients and also our staff. All right. So it all starts with really all this zoning in mind, and the flexibility have to be such that it can start with a small proportion of infectious patients. It can ramp up. The number of facilities to be converted, it should be able to be converted zone by zone, or in a smaller scale, maybe ward by ward. All right. So with this in mind, we really start with the master plan in place. All right. And the master plan have to cater for also workflow, because how you start with is really the very fundamental question: how do your patient come in? Are they coming by ambulance? Are they walking? And if they are healthy or if they're infectious, how would we segregate them? All right, where's a triage point? So therefore, the entire patient journey, your logistic flow, how your clean supply, how your dirty waste go out, how your actually staff comes in. So therefore, all your resources, what are the entry exit point? And am I going to lock down the entire hospital with only one entry exit? Then what will happen to the rest? So all this master plan need to come in at a very big picture before we zero in the really minute. Perhaps I think at this point, I hand over to my fellow panelists, otherwise we can talk whole hour just on this. Yeah, maybe.
I think the suggestion is very good. One way is you define a facility for infectious disease control. We did that in Malaysia because there are few hospitals, public hospitals, which were designed for communicable disease and they were isolated in that area. But my issue is in country like Singapore, it's quite easy because it's a small country. But what about countries which have got very huge landscapes? Malaysia is not all that huge. We can still probably manage it quite easily. But what about Thailand, Indonesia, Philippines, and other bigger countries that we have? So it looks to me that you may need to have these systems embedded in almost every hospital to manage communicable and non-communicable disease. Because we had the same issue. We had this so-called COVID suspects, we used to call them the PUI, when we didn't have the rapid test and we need to do an emergency procedure on a patient which we do not know the status. And when we had to do only the PCR, today we have rapid, but when you do the PCR test, it takes about, sometimes in the early stages, it will take about 2 days before you get the test. So we were very worried, how do we take this patient into the operating room? Exactly how Seow said, it's going to be very difficult because the pathway of the patient that is going to move, we need to find an operating room with negative pressure. And it was a huge headache. How are we going to manage this patient, probably appendicectomy, without knowing its COVID status? So if we have all the systems in place, we know that once you have a communicable disease, the pathway, the way even the patient gets into the operating room and the way it gets into the operating theater and leaves, all should have been designed such a way that they are actually segregated in that manner. And these are just a practical aspect. A simple-minded person like me as a doctor, we were observing that there was some structural modification that was probably warranted.
And you all raised very good points, and I'm curious, Chih, how, since you guys are now planning for the Alexandra Hospital 2030, how will you take these points into consideration, and how did the discussions change from before COVID to post-COVID when you were talking about the 2030 campus?
Yeah, I think Xiaoqin mentioned this earlier. This pandemic situation really heightened the importance of us to not just plan a hospital for business as usual. You have to plan a hospital that's ready for war. And you don't know what type of war it is. When pandemic comes, it can come in all shapes and forms, and how the every disease is rather different. But you do need to have basic fundamentals and principles in place. And we mentioned earlier, analysts like Kuljit and Seow mentioned about work flows, how people flow. Because even in a wartime, there will be patients who you want to keep free from infection, who will still need healthcare. Previously, I think when it comes to healthcare design and when we're planning a new facility, we always think about business as usual. So most of the time, we want patients to flow in this way. Sometimes with the luxury of space and a bit of more budget, you plan back of house, front of house, how operations. And that becomes increasingly useful, especially when you have pandemic situations. However, now this is no longer something that's good to have. It's now a must-have. So for Alexandra Hospital in 2030, that's something that we have really put in almost every department that we are designing. How the people will flow, how the materials will flow, how the equipment and instruments, supplies will flow, when they're clean, when they're dirty. All these have to be looked into. And most of the time, because when you're building a new hospital or a clinic or any healthcare facility, there is always a finite amount of money in terms of budget. But if we do not look at this when we start putting our pen on the drawing, we will have grossly ill-prepared us for pandemic. So one of the big things that COVID has done is it has given us a lot of rationale to why we have to keep every flow very, very distinct and very, very separate, so that we can minimize the risk of cross-infections and keep operations going almost in the same site, but two separate operations going at the same time. One is for patients who are ill, and one is for patients who are not infected. So that is the biggest takeaway. From a hospital perspective, when I say every department has to think about it, it was just this morning I was talking about how surgical supplies, the flow of surgical supplies will have to change. Because for pandemic situations, you want to make sure that their sets are brought down in a very different route than the clean ones, or the dirty, clean patients, because you don't know how contaminated it is. So you want to make sure that they have a very different route. And that requires a lot of planning, detailed planning. So that I think is the big thing that has changed. The other things that have changed are, actually, interestingly, this whole pandemic situation has brought about the importance of staff welfare. I think this came about in Europe, where a lot of healthcare workers were really burnt out because they were worried of going home. And staff accommodation was something that was not really something people think about in Singapore because we are so scarce of land. But in Alexandra campus, this conversation has started, and we are likely going to have staff accommodation because it's extremely useful when it comes to pandemic times. So, and these accommodations can also, I mean, if you look at it from a flexible use point of view, can be used for surge capacity. in times of need. So that's something that we are also looking at. Even staff rest areas, say if you have typically pantries and rest areas are like an afterthought in healthcare design, because while staff are important, but real estate is very limited. So we wanted to make sure that we have rest areas that are big enough for patient, for care providers like doctors and nurses who are working longer than normal hours, working very, very hard and under a lot of stress because of and fatigue because of the number of patients and of course the increased processes of infection control. The chances of burnout is high. So we wanted to make sure that the future Alexandra Hospital also looks into staff welfare areas, so that we make sure that we have rest areas for patients, for doctors and nurses and we are catering for both what we call clean teams and cleaner teams. Yeah. So these are two main things that came out of it that I thought was quite interesting to share with the panel.
Yeah, and I'm curious, one topic that has been growing is telehealth and telemedicine, and using technology like everyone mentioned before. I know at the Brigham, we always had a push to increase the number of virtual visits and using the technology as much as possible to reach people in rural areas and to reduce the number of visits to the actual hospital, especially for people who can't, don't have the convenience to do that. And we've seen, there's a saying that don't let a good crisis go to waste. And we've seen some benefit that came out of the crisis, which at the Brigham, we had an increase in virtual visits of 3,000%, which is a massive percentage. So I'm curious of what the panelists think of the role of technology, and do we think of this as a pendulum that is swinging, to the way to have a lot of virtual visits, and is the pendulum going to swing back, or is it going to settle somewhere in the middle where it's an improvement for where we are today?
Maybe I will answer that as a doctor. The virtual consultation is very good. It has got its merits, but it also has got its demerits. Medical healthcare is a little bit different than your other kind of businesses that we do. You can go on your Lazada, your Alibaba, and your Amazon, and you can go virtually and do a lot of things. We can also have a conference like here, sitting in Singapore, in KL, and Zeyad, I forget where you're sitting from. You are in the UK or US? Where are you, Zeyad?
I'm right now I'm in Jordan, but I was in the US 2 months ago.
So there you are. So this kind of virtual platforms work very well, I would say. But when you come to teleconsult, you can actually use it very well for follow-up for patients who just want to inquire further after a physical contact in order to get a little bit more information or for some further discussion. But it is not worldwide. It is not applicable if you have a patient that you have not seen before. Because in medical healthcare, you need to examine the patient, you need to investigate the patient in order to come to a diagnosis. So many patients think that you can see the doctor online and then you get a prescription online and you're treated. So it doesn't work that way. So there is a benefit to a certain group of patients, which would probably sometimes you don't need the patient to come to the hospital just to talk to the doctor, because that part of it, if there's not going to be an examination, patients just need to consult to discuss something already a known condition, then yes, it is probably useful, but definitely not for a new case or for an emergency. That it will not be so applicable. So there are limitations, there are advantages. We should be clever enough to pick up the right thing and advise our patients accordingly what would be the best way to use teleconsult or use telehealth. Particularly in countries where healthcare is pretty accessible. It's different in some countries where healthcare is totally not accessible. Even then, it's best for a doctor to be on site, and together with the patient, the doctor could consult a specialist through teleconsult. Yes, that will be good, because a doctor in an outreach would be able to help patients through teleconsult for some sort of specialized care. But there is a medical personnel with the doctor, with the patient. There is very good merit for it. But Singapore and Malaysia, what's so difficult is there to go and see a doctor. Of course, when there is COVID and you just want to talk to the doctor and nothing more than that, then of course telehealth is good.
Yeah, Chih here. So I want to share that in AH, we have actually wanted to push telehealth, just like Brigham, and it was not very sexy. But when COVID came, the response grew. So we jumped on that, and we really pushed the envelope on this. So as what Dr. Kuljit shared, some specialties, the proportion of patients who would benefit of telehealth would be a lot lower, like surgery, because surgery is a very tactile practice, and in reviews they like to see and touch the patient. But for other specialties like internal medicine, sometimes for follow-up, it's actually appropriate. So we in Alexandra Hospital, we looked at all the patients who would be appropriate, and then we started to work on it. So right now our penetration is rather high in terms of virtual consult. About 17% of all our patients are on virtual consult now, which is something that is unheard of in Singapore prior to COVID, and something that we will want to continue to push, because I think patients who actually tried it quite like the convenience of it, because coming to a hospital, especially in COVID, it is, of course, poses itself risk. But I think even without COVID, when patients come down to the hospital, it's like an expedition. So especially with elderly, you're coming not on your own. You have to have your daughter or your son take leave and accompany you. And it's usually a half-day affair. So if they can do this at home, and nowadays, as long as you have someone in the household that's tech savvy who can actually set up Zoom for you, it doesn't matter if the patient is old, you can still achieve teleconsult. So we felt that was really good. A couple of things stood in the way though. Mindset is one. Not everyone was ready for it. Even if you ordered or offered to the patient, some still preferred to come to a physical hospital, even though they know that there is risk involved in COVID time. Second one is policy, interestingly, and that is, that funding policies, especially in the public hospital, government funding policies, there were some restrictions. All new patients had to be seen face-to-face. That was just the rule. So therefore, you excluded all the first visit patients. And so if we and also even review visits, and because it's such a new and savvy new thing, the policymakers had to come out very quickly in a short period of time what type of consults is funded and which type is not, especially because you're receiving government subsidies. So that counts. That's still a conversation that we are having, but I think it's definitely very positive. I personally also believe that don't let a good crisis go to waste. We must learn something from it, and overall healthcare must change and evolve to be a better one.
Yeah, I think my fellow panelists really have illustrated really how telemedicine would develop. But I would like to add on just a little perspective is that, I think Singapore is an interesting case where you actually can literally drive from one end of the country to another within 1 hour, right? I think the long gone story is always that in such a small country, how can telemedicine ever develop here, right? I think rightly Dr. Kuljit said is that if you are a big country where you happen to be at the remote rural area, and healthcare is not accessible, perhaps telemedicine is really the way to go. You don't want to spend hours, if not days, just to get to healthcare. But in Singapore, I mean, the furthest hospital that you need to go perhaps is less than 1 hour away, right? But really that this COVID-19 has brought us to a very new scenario that we never experienced before. That is, the hospital could be just maybe 10 minutes away, but because of the lockdown, you really have no way to go there. All right, so this forced a change of mindset of a lot of people, because the risks of going to the hospital or the prevention for you to even go there is so huge that if you ever want to get a consult, you got no choice, right? Either you totally don't get this consultation at all, or you actually have to go for telemedicine. And that's really like hospital, like what Alexandra, just now my colleague say, is that if the hospital is available and make this opportunity for you to really see the doctor without having to step out of the house, is really what is the next best thing you can get. All right. So previously, even though the distance is very far, very near, but no matter what, the initial is always there. All right, because it's so accessible. But now the initial is get overwritten by the COVID-19 situation. But we all know it's like something new is always sometimes scary. We don't know what we are in for, so we don't want to try because something is so readily available. It's a comfort zone. But when you have this force you to try it, and the first experience turned out to be not so bad, people will tend to just continue. All right. Therefore, from a consumer point of view, I do see that I think there's something good that come out of it. Is really like, I think what Dr. Kuljit said is not everybody is suitable for it, but there are some illnesses where the patient is very stabilized. What they really need to do perhaps is to get face-to-face talk, and also coupled with the technology nowadays, you actually can send all your bio data, all your major metric, actually literally over the handphone, right? Nowadays, actually in our Singapore hospitals, is that some patients are given some sensors, right? Something that can monitor all your vitals. And actually, this can be uploaded and it just can send back to the hospital. Therefore, when the teleconsult comes in, actually, literally, all the parameters that the doctor need to know is available. Obviously, this is only applicable for certain illnesses and not all, right? There will be many more that what Dr. Kuljit said. There's no way for you just talk to the patient for a couple of minutes and you can know what's happening. You really need to see the doctor. But there are others who are stabilized and technology make it available where all this important information can go through the web and now just follow up with a conversation. It's sort of close a loop. And I think those are the opportunity that we can look at. So I think whether it's a public healthcare or private hospital, there may be this segment of the patients where they actually could benefit telemedicine. All right. But how far it can go, it really depends also on technology and also the open-mindedness of the people in accepting the technology. Yeah.
Yeah. I think this is a great discussion. We have so much to discuss, but unfortunately we're running out of time. So I'm going to start reading some questions that are coming in. And we have a question from Rani Nathwani, which is, would you recommend that only public healthcare systems look into planning for war while private hospitals continue to focus on running healthcare as a business? Or should private hospitals also be mandated to support the public healthcare system by having their facilities ready for any pandemic? No, I think, from my perspective, in the US, the word mandate doesn't really exist. The government can mandate hospitals to do that. If the patient shows up at your hospital, you have to take care of them. There was a massive difference between, I'm going to combine this with another question, which is asking about the difference between public and private healthcare providers and the difference of the care they're providing. In the US, it was the size of the system. The bigger systems were able to handle it, but the smaller community hospitals took a big hit. But I'm curious to ask the other panelists if mandating this in other countries, like in Jordan, we can definitely mandate. We actually, only the public sector dealt with the crisis. The private hospitals were not involved at all. So I'm wondering what the other panelists, what are your perspectives?
In Malaysia, it has been an understanding that the pandemic would only be managed by the government sector. It was an understanding. Why I said it's an understanding, it was not mandated, but it was an understanding in the fact that it was believed and it also worked out well to contain the disease well, particularly COVID when the learning curve was so steep that we do not know much. It's best the patients to go to a certain group of hospitals in the government sector so that they can be managed, one, to contain it and also to quickly learn how the management is. If you have patients all over in all different kind of hospitals, there will never be experts to manage this COVID. Which is quite right. Malaysian government did it correctly because we saw in many other countries, the COVID wasn't getting the kind of management that what we saw in Malaysia, because they had different kind of opinions, different ways of managing it, and there was no real learning curve. But the government of Malaysia did tell the private hospitals, I'm the president of the Private Hospitals Association, to stand by just in case they get overwhelmed. And that's exactly what we did. We told them that we will take over your non-COVID patients if you are really stretched to the level that you can't manage, the non-COVID patients. We gave them ventilators, we gave them whatever that they need immediately. We gave them about 60 to 70 ventilators, working ventilators, not the ventilators that they were getting from other countries, which were brand new and nobody knew whether they worked. We gave them working ventilators to support them. We had that kind of partnership. So we were not mandated, but the way it was done, looking back last 6 months, it actually worked out quite well.
Okay, maybe I'll share the Singapore's perspective. So I think in Singapore, it's also very hard to mandate because we work on a free market model. It's very much like Malaysia. But what we did was there was also all private hospitals were not designed to house only infected cases, of course. And most of the operations centered around business as usual, even in pandemic times. But that did not preclude us from involving them for partnerships. And partnerships can come in many forms, loan of equipment, staff, or even facilities. So you see, one of the things is when a public hospital is a bit overwhelmed in terms of capacity and have to increase the dirty areas, the not so clean areas. And that means in the real case, we actually converted more and more wards to house infected cases, and therefore, but there were still patients who required medical care. So the two simple ways is you divert your patients to private hospital, and then they receive care there, or you could rent their facilities and then run your services over there. The way COVID has happened in Singapore, how the private hospitals got involved is they were recruited, a lot of their staff were recruited to help out in the community care facilities. And that proved extremely useful. So as a healthcare system, we must see ourselves as one, public or private, because when it's a wartime, all resources are on deck. And it's a matter of financing, how we work out the math after that. But when it's a wartime, we just have to make sure that we win, right? So, and that has worked. I think moving forward, I will still see that it's a political will thing. It might be very hard to mandate that private hospitals do certain things. Some countries would be able to get away with it, but other more free market countries like Singapore or America definitely would not be able to do that. But what we can do is we must always be open to private-public partnerships, especially in such times.
Perhaps I do have another view is where in Singapore, yes, really here's a very business-friendly country. So we won't just go and mandate without really any real justification. But I think looking at COVID-19, our experience is that just what Hsien said is that all hands on deck. All right. So in Singapore situation where there's a lot of overnight community facility that handle the less acute COVID-19 patient. Yep. Really that at a short moment, where on earth do we get so much resources, right? We talk about hundreds of thousands of people at any one time. So really, not just private hospital, even we have, interestingly, you heard about Singapore girls, right, being roped in to actually help to take care of patients. Now, those are air hostess. Not only that, we have casinos, all right? We have the really integrated resource. Now, this is a time where tourism go down to almost zero, but we have very well-trained service staff. Can they really help out in healthcare? Yes and no. Of course, the really clinical staff, they cannot. But actually in healthcare, let's say they are a large part of clinical, but they really, the other half of healthcare is really service, right? And with proper training, the service part can actually be supported by a lot of other people, all right? Not just private healthcare, but really a lot of service organization can be roped in to help out. So really, like COVID-19 situation is actually open up a very interesting scenario. Like just now earlier I said, it can be highly acute where patients are put on life support system, but there are also a lot of patients who don't show any symptom at all. All right, but there are also the intermediate one, and each of them require different type of facility and different types of care. And therefore, different types of resources can be mobilized and used. Really, I wouldn't use the word as mandated. I think in Singapore, the government approach is multi-agency, multi-organization, and both partnership between public and private. And all resources should be made available to handle a crisis like that. All right, and I think the question of mandate, somehow it conjure into not something very pleasant because you are forced by law. But really, I think the situation we see here, you don't need to be forced by law. Somehow, a crisis like that did open up a lot of opportunity where actually it could be win-win. Imagine like our integrated resource, meaning casinos, you got zero visitors, but you still have to sustain a large organization with lots of operating expenses. And do you want to sack all the people and later call them back when the business ramp up? Therefore, there must be a way to finance it and make sure all your people are meaningfully occupied. And really, I would say that one credit I always credit our government is in terms of finances, economy model, both during crisis and peacetime, we really make everything work, all right? Whether you are getting private resources to support a mission critical thing like that, it can actually be a win-win situation, all right? Not necessarily just from clinical point of view, but it's actually COVID-19 open up a surviving kind of situation. Everybody's for survival, all right? Not just from illnesses, but also from economic crisis.
I agree with Siu Kin and the rest with the same thing also. That even in Malaysia, when this pandemic was at its height, the private hospitals and private doctors also for that matter, just told the government, you tell us what you want, you just come and take it. This was wartime. We never set a calculator that you need to pay us this much. Even when they were about to decant patients to us, we were not very particular how much it's going to cost. As we just told them, send us the non-COVID. You just concentrate on COVID. You need anything, you just take it. And even we had specialists from the private who were willing to go back to the government to help their colleagues in the ICU. They were volunteers. They don't get paid anything for it. They didn't want the money. They actually wanted to help their colleagues who were actually struggling in the ICU looking after COVID patients. Like some of our anesthetists were willing to volunteer. That kind of spirit was something which we were really taken aback, that everybody wanted to chip in and help out. But not just help out and make a mess, but follow the guidelines of one stakeholder, that was the government.
All right, I think we're at the end of our session. We had a lot of questions come in that we didn't have time to talk about, like patient experience. How will the new guidelines and health facility design take that into consideration? I will give that as homework to our panelists and to our listeners to think about it. This is a continuous situation. This is something that we're dealing with, and it's, you know, we're still in the midst of it. 2021 is gonna come soon, and we're gonna still be dealing with this. I think this was a great conversation, and I look forward to talking more about this with my colleagues offline. thank you everyone for joining us, and I'll hand it over to Singh.
Yeah, thank you, speakers. Are there any last remarks that you guys would, Yeah, thank you, speakers. Are there any last remarks that you guys want to make before we conclude the discussion? Maybe each from,
Maybe I can.
I just want to say thank you for having us. We're very honored to meet my fellow panelists and learn so much too. Thank you.
Really, I also would like to express my thanks. I think it's really great that the panelists all come from different backgrounds, and really we learn from different perspective. Yeah. So I just wish that we have more time, because I think there's a lot of interesting questions. Yeah. We meet another time and really discuss more in depth.
Same, yeah. I think it was great having this session, and you know, I have so many sessions on similar topics, but sometimes we have the same group of people from the same type of industry. We are in the same industry but different specialty, and I think a lot of this can be discussed, and we have a lot more to learn. We have learned a lot, and I think we have a lot more to learn, I would say. And everything, as I said earlier, there's a silver lining for everything. Let's look at COVID in a negative way. There were also positive things that we have picked up, and which is good.
Right. And for Zeyad, if there's any concluding remarks.
Yeah, I love Dr. Kuljit's note about having a positive outlook on this whole thing. I completely agree. You know, I always try to see the silver lining in things. And we already, you know, when I was at the Brigham, we had a lot of permanent changes, like the virtual care visits, and the number of patients, not just physicians who had to get used to telemedicine, but also patients who did virtual care for the first time, and they were immediately comfortable with that. And now that I'm back on healthcare architecture, we're having conversations of what will the new health guidelines look like, and how will they incorporate these pandemic situations into the design of new facilities. So, you know, I couldn't think of a better time to be working in healthcare, and I'm very grateful to be in it. And I'm very happy that we had this session today.
All right, okay. Thank you, speakers, and thank you everyone for attending this webinar. So before you leave the webinar, you kindly help us to fill out this feedback survey for us to know, to resend it to our speakers and to improve future webinars. Yeah, thank you so much. Stay safe and take care.
Thank you.
Bye.
Bye.
Bye.